I would want each and every one of us to have a minute of silence to remember a soul for the effort he has done for the epilepsy in Africa, as well as the world as a whole. So may God bless his soul and be with his family and loved ones. So a minute silence, please, everyone. Okay. I hope it's already a minute. We thank God for that. May God accept it.
Good evening, everyone. Thank you for the opportunity just to share some few of experiences.
Hello.
My name is Kagema Joan from Kenyatta National Hospital in Kenya. Yeah, so I want to talk about autism and epilepsy and its relationship. The objectives tonight, in this afternoon or this evening, is introduction of autism and definition. What are the causes of ASD and how to diagnose a child with ASD, and the relationship between autism and epilepsy, distinguishing between epilepsy seizures and abnormal movement in ASD, intervention and the way forward, and the role of a nurse in the management. So I want to start with the definition of ASD, Autism Spectrum Disorder, which is a neurological and development disorder that begins early in childhood and runs throughout a person's life. It affects how a person acts and interacts with others and communicates and learns. The ASD is the name of a range of similar conditions, which include Asperger's syndrome that affect a person's social interaction, communication, interests, and behavior. In children with ASD, the symptoms are present before 3 years of age, although the diagnosis can sometimes be made after the age of 3. In most cases, boys are diagnosed with the condition. There are more boys diagnosed with the condition than the girls. What is the impact of ASD? It has a social skills and communication, and it's associated with narrow and rigid repetitive behavior. So ASD is not a disease. To conclude, ASD is not a disease. It affects the immature developing brain. There is no cure for ASD, but speech language therapy, occupational therapy, education support, and a number of other interventions are available to help children and also the parents and the caregivers to be able to tackle the issues with the children or persons with autism. There are 3 domains in autism, which is reciprocal to social interaction. There's the verbal and nonverbal communication, and the restricted and repetitive interest. So most of the ASD may find them in either of the domains, or some may be having the combined. I come to the causes of autism, because those are some of the things that happens, and we are asked by the parents and also the caregivers, what are the exact causes of autism, which is unknown, and is that we have several complex genetic and environmental factors which are involved. There are many genetic influences in most cases that can be multiple, and mostly with small effects on brain development. Infections before and during pregnancy, interacting environmental, which we call epigenetic, influences via the physiologic effects, molecular networks or cellular networks, and brain circuitry toxic agents like lead poisoning. There can be autoimmune disorders whereby the body produces chemicals against its own tissues, among others. So other health conditions known to be associated with autism, one is muscular dystrophy, which is a group of inherited genetic conditions that gradually cause the muscles to weaken. There is Down syndrome, a genetic condition that typically causes learning disability and a range of physical features. There can be cerebral palsy, where you can find a child with autism can also have cerebral palsy or cerebral palsy as features of autism, conditions that affect brain and nervous system, causing problems with movement and coordination. You can also, where in Down syndrome, you can always find children with Down syndrome also having autism. We can also have infantile spasms, a type of epilepsy that develops while a child is still very young, and usually before they are 1 year old. There's also neurofibromatosis. It's a number of genetic conditions that cause tumors to grow along the nerves. So how to diagnose autism? It's usually done by through the DSM, the Diagnostic Statistical Manual of Mental Disorders, or ICD. There are different countries use the DSM and the ICD to diagnose autism, like in US, and the US use the DSM, and the UN, the United Nations, uses the ICD. So in the current DSM, there is only one autism, which Autism Spectrum Disorder, which is ASD, with different levels of severity, which with support needs, which is, and as you can see that diagram, we have less severe to more severe. Before the DSM-5, we used to have former types of autism, which was Asperger disorder. There was autism, the Rett disorder, childhood disintegrative disorder, pervasive development disorder, and others. But the recent DSM-V, the diagnostic mental the DSM, it brings up, there are types that are no longer used. The previous types are no longer used. So we have only one ASD, the one Autism Spectrum Disorder. So they are with the different levels of severity, from less severe to more severe. So the others were included in one to ASD. So we don't have the different groups as the DSM-4 used to say. So DSM criteria for ASD, there is the social communication impairment, and there is the restrictive interest behaviors. So when you go to one side, you get the reduced social emotional reciprocity. There's the deficit in nonverbal communication and difficulty with the relationships. On the other side, we get the behavior problem, the repetitive movements, there's the speech, there's the ratios and routines or resistance to change, there's the restricted interest or focused interest, over and under reactivity to sensory information or unusual sensory interest. And most of the time, when you speak of ASD, sometimes you find it in the mental health. So how to diagnose? ASD is diagnosed according to DSM criteria by clinicians using semi-structured observation, standardized tests, and interviews to inform diagnostic decision. When you talk of autism diagnostic interview, which is revised, is a parental interview often used to gain information about developmental history and everyday function. This is an area where the parents usually gives the observation that he has seen pertaining the child as he is growing, because most of the times as parents usually have what we call denial, as sometimes you are not able to understand the behavior or the problems that are encountering with that child, because sometimes most of them they don't have eye contact. Sometimes they keep to themselves. So some of those things is what we call autism diagnostic interview, where we do it to the caregiver or the parent. When you come to the autistic diagnostic observation schedule, it uses semi-structured observation to measure symptoms. So some of the early signs of ASD is limited eye contact, delayed speech, more attention to objects than people, less pointing or gesturing, and less imitation. Sometimes they do the same thing over and over, getting upset when routines change, delays in motor development, overall undersensitivity to noise or touch. When you come to some of the observed, some are often but not always observed in people with ASD, those are some of the things that the symptoms or the signs that you see. Some of them is difficult reading, emotions and body language, interest in rules, odd facial expressions, speech tone or wording, high levels of honesty, very literal language, social isolated, keeps talking when others are not interested, avoids touch or eye contact. Some of them have unusual sensory or motor responses. Some have difficulty in planning, difficulty in generalize across contexts, and delayed responses. Some other of the signs you can get is good logical skills and ability to recognize patterns. They can have ability to speak than to understand other speech. They have repetitive focus on the same topic, ability to focus intensely on their attention, strong memory for facts and date, reacts intensively to changes, lapse and expected, attention to details, and enhance perception. What I mean that when a child or a person with autism has got a routine that they usually follow, and sometimes when you break that routine, they start become confused. So those are some of the things that you can observe, and some of them, they may not be always. So the relationship between autism and epilepsy, that is where we are. Epilepsy is more common in individuals with autism than the general population, which estimates includes 20 to 30%. Some estimate that more than 15% of people with epilepsy have autism traits, such as impaired social interactions, communication impairments. Studies have shown that epilepsy seizures short-circuit the neurological function in the brain that affects socialization and involves the same traits as seen in autism. There's also impairment in normal social interaction, which include eye contact, conversation, enjoying the act of sharing with someone else, entitled regimented or repetitive cycles of behavior. Some researchers believe that epilepsy medication might ease some symptoms of autism, and people with epilepsy can benefit from autism therapies that focus on improving socialization skills. So how common is ASD in patients with epilepsy? 30% of patients with autism have epilepsy. 30% of patients with epilepsy have autism. Highest risk for autism is seen in those whose seizures that start in the first year of life. So how common is epilepsy in patients with ASD? Risk for epilepsy in children with autism is higher than those with greater intellectual disability and symptomatic vis-a-vis unknown cause and history of regression. 35 to 65% of patients with autism have EEG abnormalities. Epilepsy in autism confers increased mortality. Epilepsy is more frequently in individuals with ASD than in general population. However, its diagnosis is frequently challenging. So diagnosing epilepsy in children with autism, it's difficult in distinguishing a behavior episode. It is difficult to distinguish behavior episodes like staring, repetitive movement from an epileptic seizure in children with autism. EEG may be abnormal in patients who do not have epileptic seizures. So treatment goes for epilepsy in children with autism to eliminate seizures without negatively impacting behavior or cognition. Intellectual disability, most of 38% of children with autism have intellectual disability. According to 2008 CDC, 20 to 25% of children with epilepsy have intellectual disability. Rates of intellectual disability in children with autism and epilepsy has also increased. For the core deficits in autism, psychosocial therapy is highly engaged, intensive, individualized treatment is most commonly prescribed. So in managing children with autism, most of the psychotherapy is highly engaged and should be intensive. And then individualized treatment is what should be commonly be prescribed, because each child or each person is individual. So it's individualized therapy. So children with autism who develop epilepsy, there are multiple philosophies. One is a relationship-based approach, which underlying developmental processes. There is applied behavior analysis approach, which includes the teaching behavior and skills through environmental manipulations. Things that look like seizures but are not seizures in children with ASD, there are stereotype movements that include repetitive complex movements that tend to be particular to an individual, usually worsened by excitement or anxiety. There is tic disorder. Tics are sudden, usually simple, brief involuntary movements of the face, eyes, eyelids, shoulder, or arm, and can involve other parts of the body. There is movement disorder, which is complex involuntary, dance-like movements of the arms or face that can involve the whole body and can also involve tightening of the muscles. We have also behavior disorder, complex, sometimes voluntary, sometimes involuntary movements and behaviors, usually triggered by emotions. There is also attention disorder, which is a staring episode in which the individual seems unaware. So children with autism who develop epilepsy, what is their light drug? No, according to the studies, there is no randomized controlled trials to the effects of anticonvulsants in well-defined populations of children with autism and epilepsy. So management of seizures in children with autism, small open label trials, maybe lamictal, and sodium valproate, etc. Sometimes you can use ketogenic diet or vagal nerve stimulator, and also include the folic acid. But note, anticonvulsants, psychotropic effects in autistic patients have so far been equivocal. So complications in children with epilepsy who develop autism. There is epileptic encephalopathy, a condition in which the EEG abnormalities themselves are believed to contribute to the progressive disturbances in cerebral function. There is regression or slowing of cognitive, language, or behavior developmental due to intellectual activity. And then my final thought is that autism and epilepsy coexist with other medical problems. So the neurologist needs to play as part of the child's team. So no two patients are the same. So that is where we call the individualistic therapy. Children with ASD tend to have seizures, and they are difficult to treat. They do not resolve spontaneously after a few years. Children with ASD and epilepsy tend to have more medical and behavior problems. In conclusion, seizures and epilepsy are very prevalent in autism spectrum disorder, or ASD. Subclinical electrical discharges are very prevalent in autism spectrum disorder. The reason for high prevalence of seizures in ASD is not well understood. Children with autism deserve an overnight EEG. Children with autism and seizures deserve a comprehensive medical workup to identify the underlying causes of seizures. Treatments for seizures in children with autism have not been well studied. Treatment of subclinical electrical discharges should be strongly considered in children with autism. There is a significant need for research in seizures and epilepsy in autism or ASD. So more studies should be done. Epilepsy is one of the comorbidities of ASD, and the electroencephalography abnormalities are very frequent in autism population. Abnormal EEG is most of the time not associated with seizure. Clinical interview and diagnosis of epilepsy in ASD are usually challenging. The benefit-risk ratio of any seizure treatment should be frequently and carefully evaluated. Being a nurse, what is my role in such a case? The role of a nurse is to be aware and to understand the needs of parents and caregivers, to be able to distinguish between seizures and abnormal movements in ASD, giving accurate and appropriate information, to ensure the learning of informal, friendly, and service to the parents and caregivers, to facilitate support groups and prepare them, and at the same time become their advocates. And the way forward is training of clinicians, nurses, and caregivers on the condition that they may understand on how to communicate and to handle persons with challenges rather than labeling them, learning informal parent support groups, facilitating the parents and caregiver support groups to advocate the rights of persons with disability. And that is my references. Thank you. That is Ed to my presentation. Thank you, team.
Thank you very much. It's Joan Kagema from Kenya. It's a very nice talk. Thank you very much. You are a nice presenter and officer nurse in Kenya. Thank you.
Yes.
Very interesting talk. I don't know if you have any questions. It's very interesting.
I've got a question. I've got a question for the presenter.
Yes.
Yes.
Thanks so much, Joan, for your presentation. Quite detailed and also very simple to follow for people who are non-medical, non-clinical like myself.
Yes.
So thanks so much. So you did highlight issues about the unknown cause of ASDs. It's not known really clinically what causes autism. But in the suburbs, in the villages, in the communities, people have got their own attribution. They've got things that they think this causes autism. Would you have an idea of what people in Kenya think causes autism, and what's the implication for treatment and management of ASD?
Yes. The problem, what in the community people think is about witchcraft. There's a lot of tradition things that happens, and there is a lot of things that people think about the curses. But when you go to the ground, to the community, you talk to them that this is a condition like any other, and you can live with it, because the best thing that you can do is just allow, especially the young parents, the young mothers, to be able to understand that this is a condition that you have to live, and also we keep on following up especially when the parents comes with those children during the baby welfare clinic, because that is when you learn during the milestones, whether the child has developed a speech, whether the child has delayed milestones. So from there, you can be able to learn what is the problem, and then you can be able to talk to the mother, and also the mother is able to give you, that is why we talked about the interview of a parent, so that he can always give you, and then you can be able to handle it, and then to know how to follow it to that one. Because the first person that the caregiver or the parent comes, it's through the nurse. So if the nurse has not enough knowledge about what is autism, what are the features of autism, you'll not be able to guide that parent or that person on how to manage that child, because those children come with a lot of behavior problems, which we need to behavior modification, because they need a lot of behavior modification. Others are non-verbal. So sometimes the children are not talking, and the parent is very worried that this child cannot be able to even say mama or baba. So those are some of the challenges. So unless you understand by interacting with the caregiver or the parent, so that you can be able to understand what is really happening with the child. And then from there, you'll be able to channel that parent or the caregiver on how to follow it up, because they need a lot of therapy, behavior modification, occupational therapy, speech therapy, to be able to have, and also social skills, to be able to interact with them, to be able to be integrated in the community. Thank you. I hope I've answered your question.
Thank you. I have a question.
Thank you. Thank you very much.
I don't know, Jacob, if you have another question.
Yes, please.
Yeah.
Joan, a very good presentation. You're concentrating on the children, is that right?
And even adults, young adults with autism, because they have hair and they have epilepsy. And especially in my observation, a child may not develop epilepsy during the young, but later, like I have several cases that I've written even for the cases, when they, after a later age, like I have a case that at 28 years, never had issues of epilepsy, but have developed epilepsy. And is on treatment.
Would it be possible for you to make a study out of all of your data?
Yeah, I can do that.
That would be, I think that would be great to present it, for example, in Paris next year.
Yeah, I think we should do that. I think I'll do a questionnaire on that, and then do on the type of the children. Yes, thank you.
Yeah,
that is a challenge. I'll do it. Thank you for pointing.
My pleasure. Anytime again.
Thank you.
I think it will be welcome to be
Michael.
published in our African Middle East Epilepsy Journal, Joan Kagema.
Just to add on kindly.
I asked you just if you, as Michael mentioned, if it would be published in our African Middle East Epilepsy Journal. It will be a very nice paper to host in this journal. So I have one question. I'm amazed at our presentation. I think in our French-speaking countries, all the doctors manage autism cases. So I'm surprised, but I think it's a very good option that also head nurse and nurses are also taking care of autism patients. I think it's a very good experience that we can maybe try to introduce in our French-speaking system. So I'm asking you about the genetical aspect of autism, because now we recently covered 2 genes for autism. You mentioned the tests and some clinical parameters for diagnosis. What about the genetical tests for diagnosis in your practice?
In my setup, we don't have the genetical things to assess the patient, our patients. Most of the time, we have done on issues of what I talked about, the interview of the parent, of the assessment on how the child has behaved. We monitor their growing up during after the immunization, during the baby welfare clinic, when they are being followed up during the 5 years, because most of the time we realize that during the 2.5 years, 3 years, that is when you observe that child is not interacting with the others, is not developing the speech, there is a behavior problem. Those are the parameters that we follow. But on issues of genetical, we have not reached to that level. We have not reached to that level of genetical evaluation for our children. We have not yet reached to that level.
Thank you.
And so we monitor our children. They may require the mental health clinic, but at the same time they come to the epilepsy clinic because they are combined. So we work as a team. We work as a team so that we can be able to elaborate, and that is why we have to have a neurodevelopmental clinic.
Thank you.
For such cases. Thank you.
Any other questions?
Yeah, well done, Johan. I really love your presentation, and it was quite interesting. My own question is this: like in most African countries, for almost all ailments, we always have our own solution. It may not necessarily actually cure the ailments anyway. Was there any, just for fun of it, in Kenya? Maybe we locally, how do you treat autism locally in Kenya? Just it's always like that in most African countries. We always have our own. So, what is yours in Kenya? What are the steps they take whenever someone has autism spectrum?
The problems that when there is a lot of stigma concerning the issues of autism or children with special needs. So by the time the parents accept, you have to go a lot of counseling the caregiver, counseling the parent and the family members, because there is a lot of stigma. And there is also sometimes you find that even before they have come, they have a lot of other herbalists or herbal medicine that have been tried to be given to those children or to those young adults so that they can get well. But initially, because as time is going and things are changing, people are coming to accept, because we are getting so much young mothers getting children with autism, ASD, and also we have also many who are coming up, and we have realized that there's a lot of reaching out that is required, a lot of trainings, and also to both the health fraternities, because some of these things were not taught when we were in med schools or in the nursing schools. We were not taught, but we have learned through as we get interaction and getting in touch with such parents, and we are able to help them to go through. I hope I have answered your question.
Yeah, thank you very much. So, Musimbi Epilepsy, I think you have a question.
Yes, Thank you so much. Not necessarily a question, but comments as per what one of the participants asked. And Joan, that was a great presentation. The scenario in Kenya is that the myths and misconceptions attached to autism and epilepsy seems to cut across. And as Joan has just emphasized, there is a lot of stigma, and especially in rural areas, because of lack of knowledge and a lot of ignorance on such conditions. When you have a person living with epilepsy or autism in the rural areas, that family is even isolated because they attach it to some kind of demon possession, witchcraft, or a punishment to a given family, and the person who is affected seems to be carrying the sins of that particular family. So knowledge on the condition depends on what class they are in. Joan being in KNH, Kenyatta National Hospital, she interacts mostly with the middle class, the near middle class, and the upper class. Those who manage to access such a national hospital or other better facilities from low class areas are those who have been maybe identified by non-governmental organizations or private organizations. There's still a lot of burden on autism and epilepsy in Kenya in rural areas because of lack of adequate occupational facilities and therapies for these children, and also accessibility to various facilities. Not all health facilities have such therapies. In terms of alternative treatment, being a community worker who has done a lot at the community levels, people opt to prayers, they opt to using certain herbs to try to massage those kids in the hope that they'll be stronger, they'll be stable. I came across a scenario in Nyanza part of Kenya where a certain herbalist used a nail to screw through the head to remove the bad blood that is making this child with autism behave the way they behave. So those are personal observations and encounters on the ground. Thank you.
Thank you, Musimbi. Before letting you waiting, raising your hand. I don't know if there are any other questions. Maybe Mr. Mortala Bonkoli, if you can.